Hi guys, so in today's lecture we will discuss stroke, medical stroke, not the slang stroke. But in this particular lecture, for proper understanding, we will discuss multiple slang mnemonics. For example, in case of frontal lobe lesions, we will discuss frontal lobe sucks. Because in case of frontal lobe lesions, there can be reappearance of sucking reflex, that is reappearance of primitive reflexes. Similarly, in case of internal capsular lesions, there can be pure motor stroke. Suppose there is lesion in right-sided internal capsule, it will result into complete paralysis of left side of body, and therefore patient might become all right. That is not all right actually, that is all right sided because left side will be completely paralyzed. So let's start. Right, so here you can appreciate two types of stroke, that is ischemic stroke and hemorrhagic stroke. Ischemic stroke is more common and carries better prognosis as compared to hemorrhagic stroke. Ischemic stroke can be of two types, thrombotic or embolic. And what is most common site of hemorrhagic stroke? It is your putamen. So we will discuss all these things in detail. But before moving ahead, let's develop few logics, okay? In our discussion on cardiovascular system, we have studied angina. Angina simply means ischemia of cardiac muscle. This angina can progress into myocardial infarction, that is also known as heart attack. In case of myocardial infarction or heart attack, there will be cell death, necrosis resulting into scarring in cardiac tissue. So this angina is reversible, whereas this myocardial infarction or heart attack is your irreversible phenomena. So in this particular discussion, I am going to relate cardiovascular problem with central nervous problem. Try to understand. In case of nervous system, you have transient ischemic attacks, and transient ischemic attacks can progress into cerebrovascular accidents or stroke. So here as well, this transient ischemic attack is simply ischemia and it is fully reversible. Whereas in case of stroke, full recovery might not be possible. So angina simply means there is ischemia which is reversible, whereas myocardial infarction or heart attack is irreversible because it results into cell death, necrosis. Similarly, you have transient ischemic attacks. In transient ischemic attacks, neurological deficit completely recovers within 24 hours, whereas in case of stroke, that is cerebrovascular accident, full recovery might not be possible, and if it is possible, it will take more than 24 hours. Okay, so here you have reversible changes, whereas in case of myocardial infarction or stroke, there is permanent damage because there is cell death, there is necrosis due to lack of blood supply. Okay, so this is basic understanding. Here you can appreciate ischemic stroke, and this is your hemorrhagic stroke, and this is your transient ischemic attack. That is sort of warning sign of stroke. Okay, the way angina is warning sign of myocardial infarction. So this transient ischemic attack, as the name itself indicates, this is transient phenomena, this is reversible phenomena, and in this case there is complete recovery within 24 hours, right? And important point over here is that there will be improvement in first hour itself. Okay, so this is again important. We will discuss all these things in detail. Now in this particular lecture we will mainly discuss cortical stroke, that is ischemic cortical stroke, and ischemic capsular stroke involving the internal capsule. In subsequent lecture we will talk about brainstem syndromes. Okay, so let's develop few more understanding. Here you can appreciate picture of actor Amir Khan. In the movie Gajni, Amir Khan was hit over his head with help of iron rod by the villain. So this resulted into brain damage, and this resulted into short-term memory loss. So in the movie Gajni, Amir Khan was hit by iron rod, okay, and this iron rod resulted into significant trauma, and it resulted into short-term memory loss. Why we are discussing Gajni over here? Because this short-term memory loss is characteristic of hippocampal injury. So in case of cortical stroke, if something is wrong with the temporal lobe, it can affect the hippocampus, and now, patient can develop short-term memory loss, also known as antegrade amnesia. Okay, so this is basic understanding. This temporal lobe is also related to hearing. Here you can appreciate a totally clueless girl. this girl might not even realize her very first boyfriend, okay? And this particular undue unfamiliarity is known as jamaisu. Jamaisu. This is opposite of deja vu. In case of deja vu, you might not have met that particular person, not known as well, but still you will feel very familiar when that particular person comes in front of you, okay? And in this basic part itself, I have one more syndrome for you by the name of Anton syndrome. This is related to occipital lobe. In this particular case, there will be decrease in blood supply of the occipital lobe due to occlusion of bilateral posterior cerebral arteries. And because occipital lobe blood supply is compromised, therefore in this particular case there will be vision loss. But few more collaterals and arteries also supply your occipital lobe. Therefore in this case there can be slight vision left. And because of this slight vision is still persisting, this person might not accept that she or he is blind. This particular condition is known as Anton syndrome, and this is related to bilateral posterior cerebral artery occlusion. Here you can appreciate a phenomena by the name of hemi neglect. You can appreciate that this guy has shaved towards the right side of his face, but he has neglected the left side. This particular condition is seen in non-dominant parietal lobe lesions. So we will discuss all these things in detail. In this particular lecture, we will also talk about brain hemisphere dominance, okay? And in mostly right-handed persons, left cerebral hemisphere is dominant. We will discuss, okay? Right, here you can appreciate the cerebrum. In this particular lecture, we will mainly talk about cortical stroke, and in this particular lecture, we will see that this cerebrum is composed of four lobes: frontal lobe, parietal lobe, temporal lobe, and occipital lobe. And in this particular lecture, we will discuss functions of each and every lobe of cerebrum and stroke due to involvement of each and every lobe of cerebrum as well as its blood supply. Okay, so in this particular lecture, we will discuss cortical stroke due to involvement of this cerebrum, right? And in this particular case, as a stroke is a vascular phenomena, in this case sometimes there will be involvement of anterior cerebral artery, sometimes there will be involvement of middle cerebral artery, and sometimes there can be involvement of posterior cerebral artery. We will discuss in detail, and in later part of lecture I will also discuss problems related to the ischemia of internal capsule, and this particular thing is known as capsular stroke. In this particular condition, we will discuss dense hemiplegia, and this can result into pure motor stroke as well. Now, for understanding of stroke, you guys must understand the blood supply of various parts of cortex and internal capsule as well. So in this particular lecture, we will study blood supply of various parts hand in hand. Here you can appreciate the brain stem. Brain stem stroke and syndromes will be discussed in subsequent lectures. So in this particular lecture, we will talk about cortical stroke, and we will also talk about capsular stroke due to involvement of internal capsule. What is blood supply of internal capsule? Mainly it is supplied by M1 part of middle cerebral artery. Okay, we will discuss, known as lenticulostriate arteries. Right. Here you can appreciate various lobes of cerebrum. On the anterior aspect, mark my words, on the anterior aspect you have frontal lobe. On the posterior aspect you have occipital lobe. So by common sense, if you have three cerebral arteries, anterior cerebral artery must be supplying your frontal lobe, posterior cerebral artery must be supplying your occipital lobe. Now you are left with only middle cerebral artery, and this middle cerebral artery supplies on inferolateral aspect of brain. Okay, here you can appreciate that this MCE supplies your parietal lobe and temporal lobe. Okay, so we will mainly discuss blood supply and related problems in the blood supply resulting into cortical and capsular stroke in this particular lecture. In between frontal lobe and parietal lobe you have central sulcus, and in between parietal lobe and occipital lobe you have parieto-occipital sulcus. You can also appreciate one more sulcus over here which will separate your frontal parietal from the temporal lobe, and this particular sulcus is known as lateral sulcus. This is also known as sylvian fissure. And when we will discuss subarachnoid hemorrhage, we will also discuss presence of blood in this particular sylvian fissure. So as of now, for general understanding, you have frontal lobe separated from parietal lobe with help of central sulcus, and parietal lobe separated from occipital lobe with help of parieto-occipital sulcus, and then you have sylvian fissure that is known as lateral sulcus dividing your frontal parietal lobe from the temporal lobe. Okay, and here you can appreciate a very important midline structure, that is your longitudinal fissure. In understanding of stroke, this longitudinal fissure is very important, we will discuss. Here you can appreciate left cerebral hemisphere, and here you can appreciate right cerebral hemisphere. And we did talk about the dominance. In most people, left cerebral hemisphere is dominant because most people are right handed. So left cerebral hemisphere is mostly dominant because majority of people are right handed. Even I am right handed. If I am right handed, right hand is represented by left hemisphere of your brain. So left cerebral hemisphere will be dominant, and dominant cerebral hemisphere is also responsible for speech. In case dominant side is affected, it will also compromise the speech. Okay, whereas non-dominant hemisphere, particularly if we talk about parietal lobe, it will be related to mainly drawing skills, right, resulting into apraxia. We will discuss all these things in detail with more understanding. Here you can appreciate longitudinal fissure. Now here itself try to understand one thing. If it is your one hemisphere, this is your other hemisphere. In between your cerebral hemispheres, you have what? Longitudinal fissure. And you guys must be remembering the homunculus. This is longitudinal fissure. Lower limbs are hanging in this longitudinal fissure. Okay, lower limbs, longitudinal fissure. So in case there will be any problem related to the blood supply of the anterior part of longitudinal fissure, it will result into weakness of lower limbs. Try to understand. This is your frontal lobe, this is your parietal lobe, this is your occipital lobe. So here blood supply of frontal lobe is mainly by anterior cerebral artery, and blood supply of this medial aspect, that is areas around longitudinal fissure, is also via anterior cerebral artery towards the anterior aspect, and this area represents your lower limbs. So in case of occlusion of anterior cerebral artery, mainly clinical features will be related to the involvement of frontal lobe as well as to the medial aspect of cerebral hemisphere. See, by common sense you can appreciate that anterior cerebral artery must supply anterior part of brain. And what is anterior part of brain? That is your frontal lobe. Plus the anterior cerebral artery will also supply structures on the medial aspect of cerebral hemisphere. This is one cerebral hemisphere, this is the other cerebral hemisphere, and you have medial aspect over here, and these anterior cerebral arteries will supply medial aspect, right, that is areas around this longitudinal fissure. And I did mention that this represents your lower limbs, motor as well as sensory homunculus. So due to involvement of anterior cerebral artery, there can be lower limb weakness along with clinical features related to the frontal lobe. Okay, here you can appreciate various lobes of your cerebrum. You have frontal lobe, you have parietal lobe, you have temporal lobe, and you have occipital lobe. Frontal lobe is mainly related to personality and behavior. How you guys are going to remember this particular thing? Frontal lobe is in front. When you happen to analyze someone's personality and behavior, you need to meet from the front. Okay, so this frontal lobe is responsible for behavior and personality. Other functions are also there. As of now, just remember this particular thing. This parietal lobe is mainly related to speech. If we are talking about the dominant hemisphere, it is related to speech. If we are talking about non-dominant hemisphere, it will be mainly related to drawing skills. Okay, for the sake of understanding, I am just going very crisp. In case of parietal lobe lesions, there will be one dominant parietal lobe, and this dominant parietal lobe will mainly be responsible for production of speech. Therefore, in case of dominant parietal lobe lesions, there can be loss of speech, and this particular thing is known as aphasia. Okay, so if there will be any problem related to this dominant parietal lobe, it will result into aphasia, particularly global aphasia. On the other hand, you have non-dominant parietal lobe as well. Non-dominant parietal lobe. This non-dominant parietal lobe is related to drawing skills, right? My drawing is very poor. Any problem in this non-dominant parietal lobe will result into apraxia, particularly known as constructional apraxia we will discuss. So this dominant parietal lobe is mainly related to speech. Non-dominant parietal lobe is mainly related to drawing skills, and there are other functions as well. As of now, just remember this much. Now, this parietal lobe is also related to reasoning, judgment, calculation and all these things. So if dominant parietal lobe will be affected, mainly speech will be affected along with reasoning, along with calculation we will discuss. Here we have temporal lobe. Temporal lobe is mainly related to memory because hippocampus is present here. This is your temporal lobe. So this is also related to hearing. Okay. On the other hand, on the posterior aspect, you have occipital lobe supplied by posterior cerebral artery, and everyone knows that this is related to vision. So this is basic understanding of various lobes of cerebrum which can be involved in cortical stroke due to involvement of anterior, middle or posterior cerebral arteries. Based on the clinical features and presentation, you guys should be able to localize the site of cortical stroke. Okay, we will discuss each and everything. Here you can appreciate homunculus. This is sensory homunculus and this is motor homunculus, and here as well you can appreciate that in the longitudinal fissure you have your lower limbs hanging. So any problem happening around this anterior aspect of longitudinal fissure can result into lower limb weakness, and this area is mainly related to the anterior cerebral artery. This is your frontal lobe beyond any doubt, and this is your anterior aspect. I did mention that this anterior cerebral artery supplies anterior part, that is frontal lobe, as well as medial aspect of your cerebral hemispheres, and over here you have representation of legs. Therefore, due to involvement of this anterior cerebral arteries, frontal lobe will be affected, as well as it will result into lower limb weakness. If there will be bilateral involvement of anterior cerebral artery, both lower limbs will be involved, resulting into paraparesis or paraplegia. Okay, this is basic understanding. This is area of middle cerebral artery, and if middle cerebral artery will be involved, it can result into face paralysis, it can result into upper limb paralysis. So in case of anterior cerebral artery lesions, problem mainly is related to the lower limbs as well as frontal lobe, whereas middle cerebral artery lesions result into problems related to parietal and temporal lobe, and in this case mostly there will be facial weakness along with weakness of the upper limb. So this is basic understanding. Anterior cerebral artery occlusion will result into lower limb weakness along with frontal lobe involvement. We will discuss various clinical features related to frontal lobe lesions, whereas middle cerebral artery occlusion will mainly result into face and upper limb weakness along with clinical features related to parietal and temporal lobe. I think this is very simple. In the initial part itself I have told you few logics, okay, for understanding stroke. Here you can appreciate broadman areas. These broadman areas are also very important, and you guys must know about few of the broadman areas. Take example of area number 44, and everyone knows that this particular area is known as Broca's area. This is related to word output, this is related to fluency of speech. In case this particular area is affected, it can result into non-fluent speech. Okay, so this is related to fluency of speech, this is related to word output. If this area is compromised, it can result into Broca's aphasia, also known as motor aphasia. Similarly, half of 44 is 22, and this particular area is known as Wernicke area, and this area is responsible for understanding comprehension of speech. If this area is damaged, it will result into lack of comprehension, lack of understanding of speech, and this particular area is known as speech reception area. So in this particular case, if Wernicke area will be absent, comprehension understanding of speech will be lost. So if there will be any problem related to these centers, it will be known as aphasia. If Broca's area becomes non-functional, it will be known as motor aphasia or Broca's aphasia. If Wernicke area becomes non-functional due to involvement of particularly middle cerebral artery and that too of dominant side, will result into sensory aphasia. We will discuss aphasia as well in detail. Okay. Here you can appreciate blood supply of brain and brainstem, and you can also appreciate circle of Willis. This particular circle is circle of Willis. So in brain you have anterior circulation and posterior circulation. This anterior circulation is mainly via internal carotid artery. This posterior circulation is mainly via vertebral artery. This is very simple diagram. You guys just need to practice it again and again. Okay. This internal carotid artery gives rise to middle cerebral artery as well as anterior cerebral artery. This forms the anterior circulation. But this anterior circulation is linked to the posterior circulation via posterior communicating artery, again branch of internal carotid artery. Here you can appreciate that vertebral arteries combine to form basilar artery, and from basilar artery arises your posterior cerebral artery. By the name itself, you can assume that these three cerebral arteries must be supplying blood to the cerebrum, that is various lobes of cerebrum. Okay, so let's redraw this particular diagram. Let's also understand the circle of Willis responsible for collateral blood supply to various parts of brain. See, in this case you can appreciate the vertebral arteries from the posterior aspect. This is your vertebral artery and this is the other vertebral artery. These vertebral arteries join to form the basilar artery. This basilar artery gives rise to your posterior cerebral artery. Too simple to understand. Now this is posterior circulation. It has to be connected with the anterior circulation. Now let's draw internal carotid artery. This is your internal carotid artery. Now this internal carotid artery will give branch to the posterior side, and this particular branch is known as posterior communicating artery. So this is your PCOM. Try to understand. This is your internal carotid artery and this branch is your middle cerebral artery. Middle cerebral artery. Now on the anterior aspect, you have anterior cerebral artery. This is your one anterior cerebral artery and this is your second anterior cerebral artery. Okay, and these anterior cerebral arteries are connected together with help of anterior communicating artery. Okay, again you can appreciate three cerebral arteries. You have anterior cerebral artery, you have middle cerebral artery, and you have posterior cerebral artery supplying various parts of cerebrum, supplying various lobes of cerebrum. Any vascular compromise in any of these arteries can result into cortical stroke due to involvement of respective cortical lobes. Okay, here you can appreciate the circle of Willis. This ensures collateral blood supply to various parts of brain. Okay, now let's also dissect this particular diagram. This is your posterior cerebral artery and this is your posterior communicating artery. This is P1 part of posterior cerebral artery and this is P2 part of posterior cerebral artery. By common sense, you can assume that this posterior cerebral artery is situated posteriorly. Therefore, it must be supplying posterior part of cerebrum. And what is posterior part of cerebrum? It is your occipital lobe and it is related to vision. Too simple to understand. On the anterior aspect, you have anterior cerebral arteries. By common sense, you can assume that this must be supplying frontal lobe. And I did tell you guys that this will also supply medial aspect of cerebral hemispheres, and any problem with this artery can result into paraparesis or lower limb weakness, that is one limb weakness, that is known as monoplegia. Okay, so here you can appreciate the A1 part before anterior communicating artery and this is your A2 part of anterior cerebral artery, that is after anterior communicating artery. So here posterior communicating artery divides P1 and P2, that is part of posterior cerebral artery. In the same way, anterior cerebral artery is divided into A1 and A2 with the help of anterior communicating artery. Majority of occipital stroke happens due to involvement of this P2. Majority of frontal stroke happens due to involvement of this A2. So this P2 and A2 are responsible for occipital and frontal strokes. Okay. Now you are left with middle cerebral artery. This middle cerebral artery mainly supplies the lateral aspects of your cerebrum, that is temporal lobe as well as parietal lobe. Okay. So this is very simple diagram. I have also made the circle of Willis. Here you can appreciate internal carotid artery, and you have 5 branches of internal carotid artery. For the sake of understanding, I am telling this particular diagram. You have ophthalmic artery, anterior cerebral artery, middle cerebral artery, and then you have posterior communicating artery, and this is your anterior choroidal artery. So these are 5 branches of internal carotid artery. So you can appreciate the first branch of internal carotid artery. Okay. So first branch of internal carotid artery is your ophthalmic artery. And by common sense, once again, you can understand that if there will be occlusion, I mean transient occlusion of this ophthalmic artery, it can result into unilateral vision loss. And this will be temporary. This can be permanent as well, okay, if not treated properly. So this particular thing due to occlusion of ophthalmic artery is known as amaurosis fugax. Okay, too simple to understand. In the similar way, if there will be problem related to anterior cerebral artery, it will mainly disturb the frontal lobe. If there will be problem related to middle cerebral artery, it will mainly compromise the functioning of parietal lobe and temporal lobe. Similarly, on the posterior aspect, we have already discussed your posterior cerebral artery supplying your occipital lobe. Here you can again appreciate the blood supply of brain and brainstem. Let me enlarge this particular diagram. This is your internal carotid artery. This is your middle cerebral artery. This is your anterior cerebral artery. This is your anterior communicating artery. This is your vertebral artery. This is your basilar artery. This is posterior cerebral artery. And this is your posterior communicating artery. We did discuss that. This posterior communicating artery divides posterior cerebral artery into P1 and P2 part. This P2 part supplies blood to your occipital lobe. So occipital lobe stroke is mainly related to the occlusion of P2 part of posterior cerebral artery. Similarly, this anterior communicating artery divides your anterior cerebral artery into A1 part and A2 part. Majority of frontal lobe stroke are related to A2 part of anterior cerebral artery. This is basic understanding, and this particular circle is known as circle of Willis. Too simple to understand. Okay, now I hope you guys understand circle of Willis, anterior circulation and posterior circulation of brain. Here you can appreciate 3 arteries which will be supplying your cerebrum. You have anterior cerebral artery, you have middle cerebral artery, you have posterior cerebral artery. See, we have discussed majority of things with help of common sense. Let's again appreciate that fact. On the anterior aspect and on the superior aspect, your anterior cerebral artery will supplying the blood. And on the medial aspect, we did discuss that towards the medial aspect of your cerebral hemisphere, you have anterior cerebral artery. So this anterior cerebral artery will be supplying your frontal lobe, superior aspect, as well as towards the medial aspect of your cerebral hemisphere. Now, what about the middle cerebral artery? See, you can very easily appreciate this is your middle cerebral artery. This will be mainly supplying towards the lateral aspect of brain, I mean cerebrum. And then you are left with posterior cerebral artery, and this is again common sense. This posterior cerebral artery will supply majorly to the occipital lobe, that is posterior part of cerebrum. Okay, now understanding this basics will help us understand various strokes and localization of various cortical strokes. Okay, here you can appreciate Wernicke's and Broca's area. These are your speech areas. But what is relevance of speech in stroke? See, you have dominant cerebral hemisphere, mainly related to parietal lobe. I am right-handed, my left cerebral hemisphere should be dominant. And this dominant cerebral hemisphere, I mean parietal lobe, will also control my speech. In case I have lesion towards the left side, it will result into right-sided hemiplegia or hemiparesis along with speech loss. Whereas in case my right parietal lobe gets damaged, it will only result into contralateral, that is left-sided paraplegia, but speech might be intact. Okay, so this is relevance of Broca's and Wernicke's area, that is production of speech, and these areas are functional only in the dominant side. So this Broca's area, as we have already discussed, is Brodmann area 44, and half of Broca's area is your Wernicke's area, that is area number 22. This is mainly related to comprehension of speech, that is understanding of speech, and this Broca's area is mainly related to word output, fluency. This is mainly known as motor area of speech, and this is mainly known as sensory area of speech. Therefore, Wernicke's aphasia is also known as sensory aphasia. Broca's aphasia is also known as motor aphasia or expressive aphasia. We will discuss aphasia. But why we are discussing these speech areas? Because these are related to the functioning of dominant lobe, particularly dominant parietal lobe, right? So this has to be noted. Speech is function of dominant parietal lobe. And I have also told you guys the main function of non-dominant parietal lobe. If there will be any problem related to this dominant parietal lobe, it will result into lack of proper speech, and this particular thing is known as aphasia. If there will be problem related to non-dominant hemisphere, that is non-dominant parietal lobe, it will compromise with the drawing skills, that is known as apraxia. Okay, as of now this much is enough. Here you can appreciate cortex, here you can appreciate internal capsule, and here you can appreciate brainstem. In this particular lecture we will discuss cortical stroke in detail, right, which can result into contralateral hemiplegia along with aphasia, apraxia, abulia, etc. And then we will discuss internal capsule lesions resulting into capsular stroke, resulting into dense hemiplegia. It might also result into pure motor stroke as well, right? So in this particular lecture we will discuss cortical stroke related to each and every lobe of cerebrum. We will also discuss capsular stroke, but in this particular lecture we will mainly focus on ischemic etiology. Okay, and in subsequent lecture I will talk about brain stem stroke or syndromes. We will discuss hemorrhagic lesions in some separate lecture. Okay, right, now let's discuss cortical stroke in detail. Here you can appreciate frontal lobe, temporal lobe, parietal lobe and occipital lobe. We will discuss cortical stroke involving these lobes one by one. Let's first take up your frontal lobe lesions, particularly due to decreased blood supply of frontal lobe due to involvement of anterior cerebral artery. So this frontal lobe is related to anterior cerebral artery. No need to repeat again and again. And what is main function of this frontal lobe? It is related to personality and behavior. So by common sense you can understand that if there will be any compromise of function of frontal lobe, it might disturb the personality and behavior of person. Okay, along with this there are other manifestations as well which can result due to involvement of frontal lobe. Let's discuss one by one. Here you can appreciate the anterior part of frontal cortex known as prefrontal cortex. This is mainly responsible for empathy. What is empathy? Empathy is understanding or realizing someone's pain and suffering while keeping yourself in his or her place. Okay, so if there will be frontal lobe lesion, this empathy component will be gone. It will result into apathy. Okay, there are other parts of frontal lobe as well. On the medial aspect, you have medial frontal lobe, and this medial frontal lobe is also known as paracentral lobule, and this is related to the activity of bladder and rectum. Therefore, if this paracentral lobule is disturbed, particularly due to decreased blood supply via the anterior cerebral artery, this will result into loss of bladder and bowel control. Okay, so as of now we have discussed that prefrontal cortex is responsible for empathy. As of now we have discussed that paracentral lobule is related to bowel and bladder function, rather bowel and bladder control. Therefore, in frontal lobe lesions, you can have two main manifestations. If this particular cortex is damaged, it can result into apathy. No empathy, no sympathy. Opposite of that is apathy. If there will be involvement of paracentral lobule, this can result into loss of bladder and bowel functions or control, resulting into inappropriate defecation and urination. That is, this person might defecate in public place as well, might start urinating in public place as well. Over to it, in frontal lobe lesions, we have already discussed that it can relate to personality problems, it can relate to behavioral problems. So these are various manifestations if there is compromise of blood supply to the frontal lobe. Here you can appreciate the Morose reflex. What is this? This is neonatal reflex, newborn reflex, or primitive reflex. See, this frontal lobe is responsible for suppression of primitive reflexes. So this Morose reflex is primitive reflex. What are the other primitive reflexes? See, you have rooting reflex, you have sucking reflex. In neonates, you have sucking reflex. In adults, you don't have sucking reflex. You can have voluntary sucking, but as a reflex, this sucking reflex is absent. Okay. So in primitive reflexes, you have Morose reflex, you have rooting reflex, sucking reflex, you have grasp reflex. These reflexes are suppressed by frontal lobe. Okay. So during development, when frontal lobe matures, these are suppressed by frontal lobe. Now, in this particular discussion, we are discussing problems related to frontal lobe. So, in this condition, we are discussing that there will be vascular compromise resulting into decreased blood supply to this frontal lobe. Now, frontal lobe functioning will be affected. So, this suppression of neonatal or primitive reflexes is not going to happen. Therefore, in frontal lobe lesions, there can be reappearance of primitive or neonatal reflexes. Okay, this is important. In frontal lobe lesions, there can be reappearance of neonatal reflexes, that is primitive reflexes. For example, rooting reflex, sucking reflex. But point which has to be noted over here, Morose reflex should also reappear, but this Morose reflex never reappears. Rest of the primitive reflexes reappear in case of frontal lobe lesions due to vascular compromise due to involvement of anterior cerebral artery. Okay. Now, last but not the least, one more important point. See, you have Brodmann area number 8 related to frontal eye field. What is this frontal eye field? Responsible for conjugate horizontal movement of eyes, also known as saccadic eye movements. Try to understand. If I intend to look towards my right, then my right lateral rectus supplied by 6 cranial nerve will contract and take my eyeball laterally. What will happen in this eye? If I intend to look towards my right, this eyeball will move this side. It means that in this particular eye, my medial rectus will be functioning, supplied by third cranial nerve. Therefore, for conjugate horizontal movements, you need functioning of two muscles, that is lateral rectus as well as medial rectus. Okay, and this lateral rectus is supplied by 6th cranial nerve, medial rectus is supplied by 3rd cranial nerve. Of course, there needs to be some connection for this movement between 3rd cranial nerve and 6th cranial nerve. This is also facilitated by this frontal eye field via these paramedian pontine reticular formation known as PPRF. This PPRF is connected to the 6th cranial nerve, and now this 6th cranial nerve is connected to the median longitudinal fasciculus, and this median longitudinal fasciculus is connected to the 3rd cranial nerve. Okay, it is very simple actually. I mean to say that this frontal eye field is connected to the opposite side 6th cranial nerve and same side 3rd cranial nerve. Try to understand. This will promote the action of medial rectus, this will promote the action of lateral rectus, and this will take the eyeball towards this side, and this will again facilitate the eyeball moving this side. So when there is normal functioning of frontal eye field, eyeball, that is gaze, will be towards opposite side. Too simple to understand. Now, as we are talking about frontal lobe lesions, this functioning will be hampered. Therefore, instead of gaze towards the opposite side, in case of frontal lobe lesions, gaze will be deviated towards the side of lesion. This is totally opposite to the lesions of brainstem. Try to understand once more. This frontal eye field, once again, frontal eye field of this side is connected to pontine paramedian reticular formation, that is PPRF of other side, and this PPRF of other side is related to your sixth cranial nerve that involves the functioning of lateral rectus, and this sixth cranial nerve via medial longitudinal fasciculus is connected to the other side of oculomotor nucleus, that is third cranial nerve that is related to the functioning of medial rectus. Try to understand. First, this lateral rectus will operate. This will take eyeball towards this side, and then this medial rectus will operate, and this medial rectus will again take this eyeball towards this side. So this is conjugate movement of eye facilitated by your frontal eye field, facilitated by your PPRF, facilitated by your abducent nucleus along with medial longitudinal fasciculus along with third cranial nerve nucleus. If there will be lesion of frontal eye field, right, think just opposite. If there will be lesion of frontal lobe resulting into problem in the frontal eye field, eye gaze will be towards the side of lesion. This is simple thing, okay. In brain stem lesions, just try to appreciate this particular fact. This thing will be opposite, that is in brain stem lesions, gaze will be on the contralateral side of the lesion, okay. Now let's discuss mega mnemonic related to the frontal lobe, and this mnemonic is very simple. Frontal lobe sucks, okay. Don't take this mnemonic literally. This sucks means that in this particular case sucking reflex will reappear, okay. So we have already discussed that in this particular case primitive reflexes might reappear except the Morose reflex. I hope you guys will remember this particular point, and all other features will also be related to this letter S. See, if this frontal lobe sucks, then it will also suck the eyeball, resulting into deviation of gaze towards the side of lesion. Therefore, there will be deviation of gaze towards side of lesion. Too simple to understand. Okay, now let's discuss other clinical manifestations as well related to this sucks. So everything is going to start with S. This person will become antisocial. This person might become very aggressive. This person will become anti-shy. Again, you have S over here. This person can urinate. This person can defecate at any place. Related to inappropriate behavior, related to the paracentral lobule, related to the loss of bladder and bowel control, right? That is urination and defecation at inappropriate places. Now, you have other S as well. This person will also become anti-speech. This person will lose desire to speak at all. This particular thing is known as abulia, right? And last S, this person will also become anti-sympathy. We did discuss that prefrontal cortex is related to empathy and sympathy, and anti-sympathy is known as your apathy. So now you can conclude that frontal lobe lesions can result into abulia, that is lack of desire to speak, can result into apathy, can also result into aggressive behavior, can also result into appearance of primitive reflexes, can also result into deviation of gaze towards the side of lesion. So I think this is simplest explanation possible for the understanding of frontal lobe lesions, and you guys know that frontal lobe lesions happen due to involvement of anterior cerebral artery. Now here you can appreciate that this particular area is related to the blood supply of anterior cerebral artery. This is anterior aspect and this is your frontal lobe. Try to appreciate one more thing. We did discuss that this is your longitudinal fissure, and as per previous discussion you can recall that I did mention that your lower limbs will keep on hanging in this longitudinal fissure, and this particular area belongs to the territory of anterior cerebral artery. So if there will be occlusion of anterior cerebral artery, it will result into weakness of lower limbs. If there will be bilateral occlusion of anterior cerebral artery, it will result into bilateral weakness of lower limbs, and that particular thing is known as paraplegia. So in anterior cerebral artery lesions, there will be weakness of lower limbs in particular, okay. Whereas In case of middle cerebral artery lesions, there is mainly weakness of face as well as weakness of upper limbs far more as compared to weakness of lower limbs. Plus, there will be manifestations of frontal lobe lesions, and now you guys understand the mnemonic frontal lobe sucks. So this is complete description of frontal lobe lesions as well as lesions involving the anterior cerebral artery. Okay, now let's move ahead. Here you can appreciate the anterior cerebral artery. Here you have middle cerebral artery and posterior cerebral artery. Till now, we were mainly focusing on anterior cerebral artery, and these are the areas supplied by anterior cerebral artery. Here you have paracentral lobule, and somewhere in between your longitudinal fissure you have lower limbs, and other areas including prefrontal cortex has also been discussed. So these are manifestations of frontal lobe lesions as well as involvement of anterior cerebral artery. Now let's discuss second part of cortical stroke involving your parietal lobe, and by common sense you can assume that this might happen due to occlusion of middle cerebral artery, and we did discuss that in parietal lobe lesions dominance factor is very important. So you have dominant parietal lobe, and because maximum people are right handed, therefore left parietal lobe is dominant, and this dominant parietal lobe will control your speech. What about your non-dominant parietal lobe? Non-dominant parietal lobe, as we have already discussed, this will be mainly related to drawing skills. Okay, now in case of dominant parietal lobe lesions, this speech will be affected, resulting into aphasia. So if there will be problem with this particular lobe, this will result into aphasia. And by common sense, you can relate that this dominant parietal lobe, that is left parietal lobe, will be supplied by left middle cerebral artery. This non-dominant, that is right parietal lobe, will be supplied by right middle cerebral artery. And any problem happening in this particular right middle cerebral artery will result into loss of proper drawing skills, particularly known as apraxia. So in nutshell, you can assume that dominant parietal lesions will result into mainly aphasia, whereas non-dominant parietal lobe lesions due to right-sided middle cerebral artery might result into apraxia, that is constructional apraxia we will discuss. Here you can appreciate left cerebral hemisphere and right cerebral hemisphere, and this is your area of your parietal lobe, and this area is supplied by left middle cerebral artery on the left side, right middle cerebral artery on the right side. Now try to appreciate again the homunculus. You have face and you have upper limb over here. So due to involvement of left middle cerebral artery, right sided motor weakness related to face and upper limb might happen. Similarly, due to involvement of right middle cerebral artery, left sided contralateral hemiparesis involving upper limb and face might occur. But due to involvement of left middle cerebral artery, there will be loss of speech. Whereas due to involvement of right middle cerebral artery, drawing skills will be compromised. So this is basic understanding. This particular thing is known as apraxia. This particular thing is known as aphasia. Too simple to understand, but there are other features as well. Now, as of now, you can understand that middle cerebral artery occlusion of either side will result into contralateral weakness of face plus upper limbs, and this will be more as compared to involvement of lower limbs contrary to the involvement of anterior cerebral artery. Okay, now let's understand few things. Now here you can appreciate the areas of speech. Here you have Broca's area, that is mainly Brodmann area 44. Here you have Wernicke's area, that is mainly your Brodmann area 22. And connecting these two areas is your arcuate fasciculus. So this is your arcuate fasciculus. All these structures are mainly supplied by left middle cerebral artery. This Broca's area is supplied by superior division, whereas Wernicke's area is supplied by inferior division of left middle cerebral artery. Why I am highlighting left? Because we are mainly dealing with dominant parietal lobe, which happens to be your left parietal lobe. Okay, so this is your Broca's area, this is your Wernicke area. This is related to motor area of speech, related to word output, related to fluency. This is related to receptive area, that is responsible for understanding, comprehension of speech. We will discuss all these things in detail. And this arcuate fasciculus is related to the repetition. If you ask a patient to repeat something, the patient will be able to repeat only if arcuate fasciculus is intact. All these structures are supplied by your left middle cerebral artery. In case your patient is right handed, okay, then it will matter. And compromise of blood supply via this left middle cerebral artery will result into lack of function of these structures, and this particular thing will result into aphasia. And because each and every center will be affected, this will be known as global aphasia. Here you can appreciate one more manifestation. In this particular case, person is sitting, this is left side and this is right side of body, but this person is unable to appreciate the left side of body. Okay, he is only able to appreciate or acknowledge his right side of body. This particular thing is known as hemi-neglect. We did discuss in the initial part of lecture about hemi-neglect. Sometimes patient shave one side of beard, not the other side of beard, because he doesn't acknowledges half side of the body. Okay, this particular thing is known as hemi-neglect, and this particular feature is feature of non-dominant parietal lobe. As of now, we have already discussed one more function of non-dominant parietal lobe, that is your drawing skill. This is second problem which can result due to malfunctioning of non-dominant parietal lobe. So we have studied apraxia, and now we have also studied hemi-neglect. One more thing, this person is diseased, this person has some neurological problem, but this person will be unaware about his neurological problem, and this particular thing is known as anosognosia, that is lack of awareness of the disease or the neurological problem. So, in case of non-dominant parietal lobe lesions, patient will neglect everything. Patient will neglect drawing skills. Patient will neglect half side of body. Patient will also try to neglect presence of disease. Okay, so this is how you understand manifestations resulting due to involvement of non-dominant parietal lobe. Now here you can appreciate that this person is shaving only on one side, not the other side, that is not on the left side. So this is again example of hemi-neglect. So these are features of your non-dominant parietal lobe lesions. So let's again develop a mnemonic. See, the features of non-dominant parietal lobe lesions are patient is neglecting each and everything, and now you can easily assume that this non-dominant, that is mostly right parietal lobe, will be supplied by right middle cerebral artery, right? And what are the manifestations? Patient will neglect everything, therefore patient will develop hemi-neglect, that is he will neglect half side of body completely. Patient will also neglect the disease, and this particular thing is known as anosognosia, and patient will also neglect the drawing, and this will result into apraxia. We had already started our lecture with discussion on this apraxia and aphasia related to the parietal lobe lesions. Aphasia will be related to your dominant lobe. Now let's focus on dominant parietal lobe. See, this dominant parietal lobe is mainly related to speech. We did discuss about aphasia and apraxia. Now, this dominant parietal lobe has other functions to do as well. For example, this dominant parietal lobe is responsible for mathematical calculations. This dominant parietal lobe is responsible for reasoning. This dominant parietal lobe is responsible for left-right orientation. This dominant parietal lobe is responsible for reading text. This dominant parietal lobe is responsible for identification of fingers as well. Okay, finger identification, too strange. Suppose if you happen to show something like this means thumbs up, but this patient might not acknowledge that you are giving thumbs up, or boosting that particular guy. In fact, this person might not identify his own finger, and this particular thing is known as finger agnosia. Suppose you ask this person to show his index finger, he might fail to appreciate his index finger. Suppose you show this person middle finger, but this person will not be offended because this person will not be able to appreciate the meaning of fingers, okay? And this particular thing is known as finger agnosia. So these are functions of dominant parietal lobe. If there will be problem in the dominant parietal lobe, it will result into finger agnosia. It will result in problem in reading text, and this is known as agraphia. This will result into left right disorientation. It will result into problem in mathematical calculations, simple mathematical calculations. For example, 6 plus 2, that is 8. This guy will fail in class 1 mathematics, and this is known as acalculia. So in case of dominant parietal lobe lesions, there can be these manifestations as well. Apart from aphasia, we have been discussing about aphasia since long time, and these manifestations are known as Gerstmann syndrome. These are related to the lesions in dominant parietal lobe, right? In this particular case, aphasia is not included. So for understanding, dominant lobe lesions will result into aphasia, non-dominant into apraxia. Let's also discuss the mnemonic. See, in dominant parietal lobe lesions, there can be Gerstmann syndrome along with speech problems. A speech problem is very common, so you can understand. Rest of the things can be understood with the help of Gerstmann syndrome. So here you have mnemonic. Just left, right, left. Maths is best. Okay. Just over here means your Gerstmann syndrome. What next? You have left, right, left, because we are dealing with particular disease, therefore everything will be lost. In this case, left right orientation will be lost, mathematical calculation will be impossible, and therefore this will result into acalculia, and this person will not be able to read text, that is written text, and therefore this person will not be able to read this best. Instead, if you happen to show this person thumbs up, that is equivalent to best, even this person will not be able to appreciate this thumb. So in this particular case, patient will also suffer from agraphia, that is he will not be able to recognize the written text, and this person will also not be able to appreciate the finger, that is your thumb, and therefore this is known as finger agnosia. So whenever you study about dominant parietal lobe, right, this dominant parietal lobe lesions can be summarized as Gerstmann syndrome, right? But always try to remember about the aphasia as well, okay? But this aphasia is not part of this Gerstmann syndrome. Apart from this, if there is involvement of parietal lobe, if there is involvement of middle cerebral artery, there will be involvement of facial palsy as well as contralateral hemiparesis as well, in which upper limbs will be more involved as compared to lower limbs, okay? Right, let's have one more look at the artery. This parietal lobe is supplied by middle cerebral artery. Left middle cerebral artery supplies the left parietal lobe, that is your dominant lobe, and this is related to mainly aphasia plus Gerstmann syndrome, right? And right middle cerebral artery mainly supplies your right parietal lobe, and this is mainly related to your what, apraxia along with neglect, and that is hemi neglect and neglect of the disease, that is anosognosia, okay? Now we have already discussed that this will result into contralateral facial weakness and contralateral upper limb weakness more than lower limb weakness, okay? That is contralateral hemiplegia or hemiparesis. Right, now let's discuss third part of cortical stroke, which will be due to involvement of temporal lobes. And you guys know that this temporal lobe is related to hearing, and this temporal lobe has the hippocampus, that is seat for short-term memory. So this temporal lobe is also supplied by mainly medial cerebral artery. Okay, try to understand. These temporal lobes are related to hearing. Therefore, involvement of temporal lobe might result into pure word deafness. What else? I did mention that this is related to hippocampus, and involvement of hippocampus can result into loss of short-term memory, and this particular thing is known as antegrade amnesia. Here you have Amir Khan again. Amir Khan in the movie Ghazni was hit with iron rod over his head, resulting into damage of the hippocampus, resulting into short-term memory loss, okay, resulting into antegrade amnesia, right? So this is important manifestation of temporal lobe lesions, resulting mainly due to involvement of middle cerebral artery, okay. And now you can appreciate face of a very puzzled lady, and this lady is so puzzled that she is unable to recognize the face of the guy whom she dated last week, okay. And this particular unfamiliarity, that is undue unfamiliarity, is known as jamaivo, jamaivu, right? That is undue unfamiliarity. Opposite of jamaivu is your deja vu. In deja vu there is undue familiarity. Try to understand. In case of deja vu, person might not have seen another person. Still, he will feel that he has seen that person and that particular person is known to him or her. Whereas in case of Jamayu, person will feel unfamiliar to even familiar things. Here you can appreciate the hippocampus responsible for short-term memory consolidation. In case there is lesion of temporal lobe, particularly hippocampal functions are lost. And I did talk about the pure word deafness in the lesions of temporal lobe, okay. Now let's discuss last part of cortical stroke involving the occipital lobe related to vision. And now you guys know that this occipital lobe will be supplied by posterior cerebral artery branch of basilar artery, particularly second part, that is P2 part of posterior cerebral artery. And because this is related to vision, involvement of occipital lobe might result into visual hallucinations. But there are many other clinical features related to the involvement of posterior cerebral artery, related to the involvement of occipital lobe. Try to understand and try to develop one logic as well. Suppose my left parietal lobe is damaged, I might develop contralateral hemiplegia, that is hemiplegia of the right side. Suppose my right parietal lobe is damaged, I might develop contralateral hemiplegia, that is hemiplegia of the left side. So opposite contralateral involvement will be there, but that is not the case with occipital lobe. Suppose I am having occipital lobe lesion, it will not result into vision loss from right eye. Suppose I am having left occipital lobe damage, it will not result into contralateral visual loss, that is vision loss from left eye. Try to understand. If I am having occipital lobe lesion, the lesion will result into contralateral homonymous hemianopia. Suppose I am having right-sided occipital lobe lesion, it will result into loss of nasal field vision of the ipsilateral eye and temporal field vision of the contralateral eye, resulting into loss of vision on the opposite side. Suppose I am having right-sided occipital lobe lesion, I will not be able to see things on the left side, that is contralateral side. Nasal field of this eye will be affected, temporal field of this eye will be affected, half the field of each eye will be affected, and this particular thing is known as homonymous hemianopia. Try to understand. Suppose I am having occipital lobe lesion on the right side. This is left side, this is right side. This is your right eye and this is your left eye. Suppose I am having lesion in the right sided occipital lobe. This will result into ipsilateral loss of nasal field. This will result into contralateral loss of temporal field. So half the field of each eye will be affected, and due to this problem patient will not be able to look on the contralateral side, and this particular thing is known as contralateral homonymous hemianopia, right? Contralateral because opposite side vision is affected, okay. So in this case lesion was present on right side, and due to this particular problem this vision is affected, that is temporal vision of the opposite eye and nasal vision of the ipsilateral eye is affected. Half the vision of each eye is affected, okay, not only one eye involvement is there.
Let's again recap it. Suppose you have lesion on the left side of occipital lobe. Now these fibers will supply nasal field of the ipsilateral eye and temporal field of the contralateral eye. Therefore, in this particular case, this vision will be affected and this vision will be again affected. This is nasal field for this ipsilateral eye and this is temporal field for the contralateral eye. Okay, too simple to understand. So, if the lesion will be present towards the left side of occipital lobe, patient will not be able to see things on the right side. Again, this is contralateral homonymous hemianopia. And now let's discuss an interesting syndrome by the name of Anton syndrome. And this is due to involvement of bilateral posterior cerebral arteries. And now you can understand that both the occipital lobes will be affected. Patient can become fully blind. And if patient will become fully blind, patient will not have vision, but still pupillary reflexes will be normal because it is mediated by second and third cranial nerve. Okay, and for pupillary reflex you only need what? Pretectal nucleus, right? So try to understand, if there will be involvement of bilateral cerebral arteries, it will result into complete blindness, but sometimes small islands of vision might be left because few areas are supplied by collaterals or supplied by middle cerebral arteries as well. Therefore, in case of bilateral PCA obstruction, it can result into Anton syndrome, in which patient will be almost blind, but some areas of vision can be intact, and this particular thing is known as gun barrel vision. So this confident lady, though almost blind, will feel happy that at least she is seeing something, and this lady will have delusion that whatever she sees exists and whatever she doesn't see doesn't exist. So this lady will not realize, will not accept the fact that she is blind, and this particular thing is known as Anton syndrome, related to the bilateral occlusion of posterior cerebral arteries. Okay, right, let's recap. So this is your posterior cerebral artery and this is P2 part which supplies your occipital lobe, related to contralateral homonymous hemianopia, related to Anton syndrome. Too simple to understand. Visual hallucinations can also be present. But this Anton syndrome is feature of bilateral PCA occlusion. Okay, this is your middle cerebral artery, and we have already discussed this is related to the blood supply of temporal lobe, related to the blood supply of parietal lobe, and this is your A2, second part of anterior cerebral artery. This is A1, part of anterior cerebral artery. So this A2 part of anterior cerebral artery is mostly occluded in involvement of frontal lobe lesions, and in case of A2 ACA involvement, there will be lower limb weakness more than upper limb, whereas in case of MCA involvement, there will be more involvement of face and upper limb as compared to lower limb. We have already discussed rest of the points. Now let's talk about lesions of internal capsule. Here you can appreciate the internal capsule, okay? And you guys understand that internal capsule has dense fibers, okay? And therefore, due to lesions of internal capsule, there can be dense hemiplegia. Try to understand. You have internal capsule. All the descending and ascending pathways pass via this internal capsule. Therefore, if there is compromise in the blood supply of this internal capsule, it can result into dense hemiplegia. It can also result into pure motor stroke, particularly when posterior limb of internal capsule is involved. And what is blood supply of internal capsule? Blood supply of internal capsule is via middle cerebral artery, particularly M1 part of middle cerebral artery, and it is via lenticulostriate arteries. Try to understand. Here you have anterior limb of internal capsule, and this is your posterior limb, and here you have genu. This is anterior limb, this is posterior limb, and this particular thing is known as genu. In case of internal capsule lesions, particularly internal capsule lesions involving the posterior limb, it can result into pure motor stroke. Now, in case of stroke, happening due to cortex, that is cortical lesions. There will be aphasia, abulia, apraxia, multiple things. But in this particular case, there can be pure motor stroke in form of contralateral hemiplegia or hemiparesis. In this contralateral hemiplegia, there will be involvement of face as well as half of the body. So in this particular case, there will be involvement of contralateral face plus contralateral upper limb plus contralateral lower limb. That is, whole of the contralateral half side will be paralyzed. Okay. So this is related to contralateral facial palsy, and this type of facial palsy is supranuclear facial palsy. And you guys know the features of supranuclear facial palsy, in which upper half of face will be spared. Okay. So these are the features of lesions in internal capsule, and here you can appreciate the internal capsule, and you can appreciate that if there is any compromise of blood supply in this particular area, it can result into ischemic stroke involving the internal capsule, and it can result into dense hemiplegia, that is contralateral hemiplegia, including the face of the opposite side. Okay. So this results into contralateral hemiplegia, that is face as well as limbs of the opposite side are involved. Whereas in case of pontine lesions, you guys get crossed hemiplegia, that is face of one side and body of another side will be involved. In this particular case, there will be no aphasia, there will be no abulia, there will be no apraxia, because these are seen in cortical lesions, not in your capsular lesions. So this is feature of capsular lesion, that is capsular stroke. Okay. Patient will have either pure motor stroke, or patient can also have pure sensory stroke due to involvement of thalamus. Okay. Here you can appreciate the middle cerebral artery, and this is M1 part of middle cerebral artery arising from your internal carotid artery. This is your middle cerebral artery, and this is M1 part of middle cerebral artery supplying your internal capsule. Okay. So this is the blood supply of your internal capsule. Now try to appreciate one more thing. Try to learn about the various forms of aphasia. See, if there is any problem at the level of brain due to which there is speech compromise, this particular thing is known as aphasia. If there is any problem at the level of muscles of articulation, muscles of articulation, what are muscles of articulation? For example, tongue, soft palate, it will result into dysarthria. If there is any problem at the level of vocal cord, this will result into aphonia. So when we talk about aphasia, it means that cortical centers are affected, due to which speech output or speech is affected. Try to understand, you have two main areas in form of Broca's area and in form of Wernicke's area. Broca's area is motor speech area, whereas Wernicke's area is sensory speech area. This is Brodmann area 44, and this is exactly half, that is 22. With help of Wernicke's area, you develop understanding, you understand a particular language, you comprehend. Whereas with help of Broca's area, there is word output, there is fluency of speech, and in between these there is your arcuate fasciculus, important for repetition. Okay. Try to understand, this is your Broca's area, area number 44. This is your Wernicke's area. B for Broca's area, B for boy, W for Wernicke area, and W for women. Try to understand, if there will be any problem in this Broca's area, it will be known as Broca's aphasia. If there will be any problem in this Wernicke's area, it will be known as Wernicke's aphasia. Try to understand now, this Wernicke's area is responsible for comprehension, that is understanding of speech, comprehension of speech. And this arcuate fasciculus is responsible for repetition of speech. Right? Suppose you happen to ask patient to repeat anything, this patient will be able to repeat with the help of arcuate fasciculus. And this Broca's area is responsible for fluency of speech, right? That is word output. So this Broca's area is motor speech area, whereas this Wernicke's area is sensory speech area. Okay. Try to understand, here you have Broca's area, here you have Wernicke's area, and here you have arcuate fasciculus. This arcuate fasciculus is only needed for repetition. So in case of lesion involving this arcuate fasciculus, only repetition will be lost. So if arcuate fasciculus will be affected, repetition will be lost, and this particular thing is known as conduction aphasia. So in this particular case, only repetition will be affected. Now you have Wernicke's area, again write women over here, and you have Broca's area, again write boy underneath this Broca's area. In case someone is having damage of this Broca's area, he will behave like boy. Boys usually speak less, but whatever they speak does make sense. And this Wernicke's area, always write women over here. And in case of Wernicke lesions, that is in case your Wernicke area is damaged, patient will speak more and patient will make no sense. Okay, whatever patient will speak, he or she will not understand, neither others will understand. So in this particular case, comprehension will be lost. Patient will speak too much, fluency will be intact. Okay, and in this case patient will also try to fill in the blanks with the help of unknown words, that is those words which do not exist, that is known as neologism. Patient will keep on speaking senseless things, that is known as jargon speech. But repetition will also be lost in these two cases. Now try to understand these things in detail. On one hand you have Broca's area, on the other hand you have Wernicke area. This Wernicke area is supplied by inferior division of left middle cerebral artery. Try to understand, this middle cerebral artery is noted over here because we are dealing with speech, and speech is function of dominant lobe and left parietal lobe is mostly dominant. So this is supplied by inferior division of left middle cerebral artery, and this is supplied by superior division of left middle cerebral artery. Too simple to understand. If this Broca area will be affected, patient will behave like boy. If this Wernicke area will be affected, patient will behave like woman. Right? This Broca's area is responsible for word output, and here you have arcuate fasciculus. This arcuate fasciculus is also part of Broca's area. This arcuate fasciculus is also part of Wernicke's area towards the end, and we did mention that if arcuate fasciculus will be affected, repetition will be lost, right? So in Broca's lesions, this part of arcuate fasciculus will be also affected. In Wernicke's area, this part of arcuate fasciculus will also be affected. So be it Broca's area, be it arcuate fasciculus, be it Wernicke's area, repetition will always be lost in case of lesions involving these structures. In Broca's area, boys speak less, therefore word output will decrease, and therefore in this particular case fluency will be lost, and repetition will be always lost because arcuate fasciculus is always involved. Whereas in case of Wernicke's aphasia, because this women will keep on speaking, this will result into more of fluency, and patient will use new words, right, to explain things, but neither patient will understand nor the listener will understand. In this particular case, comprehension will be intact, whereas in this particular case, main thing will be loss of comprehension, because this is feature of your Wernicke's area. If there will be involvement of main left middle cerebral artery, it will result into Broca's aphasia, as well as your Wernicke's aphasia, as well as your conduction aphasia, and this particular thing is known as global aphasia. That's what we have discussed in our discussion on lesions of parietal lobe, particularly the dominant parietal lobe, because it is related to the speech. Okay, so that's all regarding cortical strokes. That's all regarding capsular strokes of ischemic etiology. Bye bye, take care.